Good afternoon, everyone, and welcome to the third day of Kidney Action Week. My name is Silas Norman, and I'm a clinical associate professor of medicine here at the University of Michigan. I have the pleasure of acting as your moderator during this interactive session, We Should All Care About APOL1-Mediated Kidney Disease. Just to give you a little background about myself, I'm a nephrologist who specializes in kidney transplantation. My research focuses on improving access to transplantation and the evaluation of medical frailty in kidney transplant candidates. In addition to my academic pursuits, I happen to volunteer with a number of well-regarded organizations, including serving on the American Kidney Fund board as the vice chair of AKF's Medical Advisory Committee. This session will describe the disproportionately higher burden of kidney disease in the Black community. While many factors are contributory, being a carrier of APOL1 variants explains a significant portion of kidney disease and kidney failure among individuals of recent African ancestry. Our panelists will discuss how APOL1 variants in addition to lack of awareness of kidney disease, lack of specific treatment, and the underrepresentation of African Americans and individuals of recent African ancestry in clinical trials are continuing at an unequal rate. Before we get started, I encourage you to join the conversation today. We'll have a Q&A at the end of our time today, but you don't have to wait until then to ask your questions. Please drop your comments in the window next to or below the Facebook live stream or the chat box if you're right here with us on the Kidney Action Week website. We'll try to answer as many of your questions as possible. Before we get started with the formal program this afternoon, I wanted to take a little time to thank our session sponsor, Vertex Pharmaceuticals. We greatly appreciate Vertex's support and partnership with the AKF, and here to speak briefly about that partnership is Vertex's Executive Medical Director for Clinical Development, Dr. Ogo Igbuna. Dr. Igbuna.
Thank you, Norman. It's a privilege to be here today at Kidney Action Week, supporting and introducing this panel on APOL1-mediated kidney disease. It's a topic that's close to my heart, both as a nephrologist, someone with family members at risk for APOL1-mediated kidney disease, and as the clinical development lead for kidney programs at Vertex Pharmaceuticals. Vertex is a global biotech company that invests in scientific innovation to discover medicines for people living with serious diseases such as cystic fibrosis, sickle cell disease, and APOL1-mediated kidney disease. At Vertex, we don't look to make incremental progress. We take on challenges where we think we can have a transformative effect, and we aim to accomplish this only by pursuing approaches that address underlying causes of disease. To that point, we are tirelessly focused on researching and discovering potential medicines aimed at treating the underlying cause of diseases such as APOL1-mediated kidney disease. As you hear in today's session, the link between APOL1 genetic variants and severe kidney disease was identified in 2010, and these genetic variants are found in people of recent African ancestry. We and others are using this genetic insight to inform our approach in the clinic today. People living with APOL1-mediated kidney disease often progress to kidney failure much faster than those living with non-APOL1-mediated kidney disease, and as such, the need for effective and safe treatments are particularly important. And as a nephrologist, I've witnessed firsthand the very difficult toll that kidney disease can have on patients and their loved ones. Not only have I witnessed the tremendous burden of the disease, but I've also listened to kidney patients expressing their hopes and dreams of a future free of debilitating disease. There's clearly a lot of work that still needs to be done, but we're excited and hopeful that we may be able to make an impact on the lives of people living with serious and debilitating disease, including people with certain genetic mediated kidney diseases. It's a passion that's shared by every employee at Vertex, and it's a passion that we share with the patient advocacy community. So before I turn the floor back to Dr. Norman, I want to commend the American Kidney Fund for the successful Kidney Action Week and for the work you do each and every day to make a significant difference in the lives of people living with rare and serious kidney disease. Thank you. And Dr. Norman, back to you.
Thank you, Dr. Igbuna. And thanks again for the generous support of Vertex Pharmaceuticals in making this event possible today. Now, let me introduce our experts for today's session. This afternoon, we are fortunate to be joined by Dr. Opeyemi Olabisi and Maggie Freeze. Welcome to you both.
Thank you so much.
Thank you.
By way of background, Dr. Olabisi is an assistant professor of medicine at Duke University. Dr. Olabisi is both a physician scientist and an assistant professor of medicine. He practices adult nephrology and conducts a number of NIH-funded research studies, leveraging patient-derived stem cell models to explain mechanisms underlying APOL1 nephropathy. He's received a number of awards, including the NIH Director's New Innovator Award. He's a Whitehead Scholar and an Albert Einstein College of Medicine alumni, Rising Star Investigator Award. And we're happy to have him with us today.
Thank you.
Maggie Fries is a licensed genetic counselor. She works in the Department of Internal Medicine at the University of Iowa Healthcare. Maggie's practice specializes in nephrology and cardiology. She received her master's degree from Indiana University School of Medicine and was certified by the American Board of Genetic Counseling in 2017. In her day-to-day work, Maggie works with family members in the Renal Genetics Clinic and the Organ Transplant Center to discuss how genetics may contribute to their kidney disease. And as our knowledge of genetics continues to grow, she believes that it's important patients understand how genetics can be incorporated into their healthcare and help facilitate personalized medicine. So thank you both for being here.
Thanks so much for the invitation.
Now, thank you. Now, Dr. Olabisi, again, thank you for being here today with us for Kidney Action Week and talking to our audience about APOL1 kidney disease. Could you please give us a brief overview of APOL1 and its connection to kidney disease?
Yes. First, let me thank Dr. Norman. Thank you for the kind introduction. I thank the American Kidney Foundation for the invitation. And thank you to Vertex for sponsoring this very important presentation. So to your question about APOL1, and to actually get the context of why this gene, which the name APOL1 stands for apolipoprotein L1, abbreviated here as APOL1. It's a small protein, about 42 kilodalton. It's part of the HDL cholesterol. People know cholesterol and HDL cholesterol. When it's made, it's secreted into the blood, and it travels with this HDL cholesterol. But that's not where we think its effect is. We know that this gene is a gene that is present in all humans. But there's a new variant of it that we believe evolved in West Africa, in the current area of current day Nigeria, Ghana area, around 4,000 to 6,000 years ago. And the understanding we have currently is that this new version of APOL1 actually protected West Africans from the parasite that causes African sleeping sickness. So that people that have this newer version are protected from this lethal disease. But it turns out that what nature gave with one hand, it took away with both hands, because this new version, if you actually inherit one from father and one from mother, now you have two, increases the risk of kidney disease in Blacks. How did they get to the America? Well, through this African slave trade, during the enforced movement of Africans, 400 years ago from West Africa to the Americas, not just the United States, but to the Caribbean as well to South America. So that's how this gene came to the America. So we'll talk more about this, but let me put it in context. Why is this important? So first, I will list 4 problems, as Dr. Norman has highlighted in the introduction. Problem number 1 is that Black people are 4 times more likely to develop kidney failure than white Americans, as shown in this graph here. In the general population, if you move to the next slide, please. Actually, maybe let's go back one. The animation was missing there. African Americans represent about 13% of US population. But when you look at people on dialysis, Black represent at least 35% of patients on dialysis. And the reason is that the rate at which Black develop kidney failure is 4 times higher than the rate which white Americans develop kidney failure. Next slide. This leads to problem number 2, which is that majority of people that have kidney disease are not aware of it. So if these 10 people in this cartoon have kidney disease, 8 of them do not know they have kidney disease, because kidney disease is silent, is often slow, progressing, and is painless. So 8 to 9 out of 10 people that have chronic kidney disease are not aware of it. And this is an important problem, especially because the burden of kidney disease is very high in the community in general, but in Black community particularly. Next slide. So what is the impact of APOL1? Remember I mentioned that this APOL1 version evolved in Africa around 4,000 to 6,000 years ago. And I will say, summarizing the literature for us here, it has two major impacts. Imagine, let's do a thought experiment, that there's a train station, and there are these two groups of individuals at the train station. One group has the normal APOL1, which we call G0. Another group has the mutated APOL1 or the APOL1 variant that originated from West Africa. And there are trains that are going to dialysis. So these train names, the names of this train actually represent the common causes of kidney failure in Black America. First is the FSGS, or focal segmental glomerulosclerosis, or hypertension-associated kidney disease, and so on. Who gets on this train? So the first impact of APOL1, the mutant APOL1, is it increases the likelihood that people that carry the variant, the mutated version, get on the train. Next. Okay, so it increases the likelihood that if you carry that variant, you are more likely to get on the train that's going to dialysis. The second impact of this gene is that once you're on the train, it turns that train to a bullet train. So there are two trains here. The train on the top is a chronic kidney disease train, in which the person in that train doesn't have the high-risk APOL1. In the lower train is a train where somebody have the APOL1 variant from Africa, 2 copies, as well as kidney disease. Which train gets to dialysis first? On average, the lower train, the APOL1 train, arrive at dialysis at about 10 years earlier than the train without APOL1, which means that APOL1 acts as an accelerant. It makes the progression of kidney disease to dialysis very fast. So two effects. It makes it likely that carriers of this gene get on the train that's going to dialysis. And two, when they're on that train, it makes that train travel extremely fast. Next slide. This is the animation of the train going to dialysis. As you can see from my illustration here, the APOL1 train gets to dialysis first. Next slide. Now, you might say, can we slow down this train? Now, the gene is found almost exclusively among people of recent African ancestry, which essentially is mostly Black individuals. It's also found in some people who are Black Hispanics that have West African ancestry. But by and large, it's mostly in people of West African origin. There's no treatment so far that slows down this APOL1 train. Efforts to treat blood pressure so far has not been shown as far in large studies to slow down the train. So this is the third problem, and this is really where effort of research is focused. I'm happy that there's a lot of research activity in companies also funded by NIH. One such study is the one funded by Vertex, or performing by Vertex to look for drug that slows down this train. Other studies funded by NIH, one of it which I'm part of, are looking for ways to slow down the APOL1 train. But for now, there's really no drug in clinical practice that slows down this train. That is the third problem. Next slide. And the fourth and the last problem is as follows. Given the number of Black people that have kidney disease, you would expect that Black people should be overrepresented in clinical trials looking for cure. But this is not so. Now, this is an illustration that shows the proportion of individuals that are represented in clinical trial. Remember, the way we find cure for disease is through clinical trial. And Blacks represent less than 5% of participants in majority of kidney disease clinical trial, which is a problem. I mentioned that Black represent about 35% of patients on dialysis, but about 5% or less of patients in clinical trial. So in order to turn this tide, in order to slow down the APOL1 train, there needs to be a concerted effort, both from the academia, from industry, but also from the community, because that's how we are going to find a drug or a treatment or modality that slows down this train. So this is the fourth problem. Next slide, please. So what's our takeaway about APOL1? So that African Americans and people of recent African ancestry have a high risk of developing kidney failure. Now, kidney failure or kidney disease in general that does not arrive at dialysis is often silent and painless. Therefore, majority of people that have it don't even know they have it. I mentioned 80% of people with kidney disease do not know they have it, and this includes APOL1 related kidney disease. Thirdly, there are multiple reasons for kidney disease in general and in Black community in particular. The role of socioeconomic determinants, including the role of racism, including the role of environment, including where we live, it matters a lot. But we cannot ignore that the role of APOL1, which was discovered 10 years ago, and several studies have proven this over and over and over again, that the impact of this gene in contributing to the excess risk of kidney disease in Black America cannot be disputed. So APOL1 gene mutation is a major contributor to the kidney disparity, kidney health disparity in the United States. And fourthly, there are no current treatment for APOL1, which really raises is an unmet need. This is an area of interest, and I'm happy to see a lot of researchers and industry focus on APOL1. Unlike another disease, I will do a little digression here. Sickle cell disease, also which affects African American, actually turned out to be one of the first diseases for which we know the genetic cause. We don't yet have a cure for sickle cell disease. We are hoping APOL1 would not be another example of that. And it's very heartening to see industry, to see people in academia rise to the challenge to try and find cure. But I think we also have to engage the community, because we cannot find a cure without a very active participation of the community in clinical trial, which is the last point here, that Black community is underrepresented in clinical trial, and we need to improve on that. The onus is on us in academia and industry, but also on the community to increase participation in trial. There are several efforts that are going on in this space, some of it led by Vertex, some of it in academic space. One of them, the one I'm involved with. Next slide, please. The Care and Justice study. You can check out our website listed here, www.kidneycareandjustice.com. This is a study funded by NIH, the taxpayer, to actually engage the community, provide screening, and also engage in a clinical trial. But there are many other studies that are going on, and I encourage you through AKF to participate in these studies. Next slide. I think this is the last slide we have.
That's it. Fantastic. Thank you, Dr. Olabisi. There was a tremendous amount of great information in there that I hope we'll be able to get into and get some more detail, get some better understanding of what we can do and to better understand APOL1 kidney disease and to move things forward. What I'd like to do right now, though, is turn to Ms. Freeze and ask Maggie, could you please tell our audience a little bit about the role of the genetic counselor in the diagnosis and education around APOL1 variants?
Yes, thank you, Dr. Norman. So I will kind of start a little bit behind here. So I'll talk you to a little bit about what a genetic counselor is, because many people probably haven't heard of that before. So a genetic counselor is a healthcare provider that has a unique specialization within both medical genetics as well as counseling. So we often meet with patients as well as their family members when there's a concern or question regarding whether or not they could have a genetic cause for a particular condition. And so our role is to ensure that patients have informed consent for genetic testing and that they've discussed and thought about all possible implications of having a genetic testing result. We can help with interpreting genetic testing results. We can identify appropriate labs to utilize for their testing, as well as other resources that patients may need. So in regards to testing for APOL1 variants, ideally it's important for patients to meet with a genetic counselor both before a genetic test is ordered as well as after to discuss, again, that informed consent for testing as well as what that testing result means to them. So as a genetic counselor, we take time to go over a patient's medical history, their family history. It's a very important tool for us. And so we can assess that information and determine if other testing is more appropriate for you, or to identify if other family members should be tested instead. We often review basic information with you about genetics and inheritance, because oftentimes people haven't really thought about genetics since high school biology or even before then. So we go over that information with you and make sure that you're up to date with that, and then try to ensure that you have a good understanding of what the testing's truly looking for and what that result would mean. We discuss all sorts of implications of a genetic testing result and what they may mean to you. There's plenty of advantages and disadvantages to genetic testing for patients, and it can be different for every person how they view those different advantages and disadvantages. So what may be a pro or con to one person could be the opposite to another. So we definitely go over that information with you. We also bring up maybe issues that patients haven't really thought of before. So one is discrimination. So with having genetic testing results within their medical record, what does that mean for their insurability? So we educate patients on the Genetic Information Non-Discrimination Act, which is called GINA. That was put in place in 2009, and it protects patients from having a genetic testing result and having their health insurance providers dropping them, denying them coverage, or increasing their premiums. They cannot be discriminated against in any way by a health insurance carrier. As well as with employment, an employer can't discriminate against a patient either based on their genetic testing result. However, there are loopholes, so we also go over those. If you have a genetic testing result, that law does not protect you from a life insurance, long-term care, and disability insurance provider from denying you coverage. So if a patient comes in and has a POL1 variant testing done and they're found to be positive for those high-risk variants, and then later on go to find a life insurance policy, they may be denied coverage. So that's something that we definitely review with patients ahead of time. Make sure that they're aware of those implications and can make the best decision for themselves moving forward. Oftentimes patients pull out a small life insurance policy for themselves first and then proceed with genetic testing later on. Another role that patients often ask about or don't expect really is the counseling aspect of this role. So it's genetic counselor. And so there is a lot of emotional issues and other concerns that can arise when discussing these genetic conditions. Many people don't predict that that would happen during these discussions. And so there can be anxieties regarding and surrounding these conditions. There can be guilt or shame because of them being genetic and being passed through a family tree. So we also serve as a resource for patients to discuss those feelings freely and really understand the genetics behind them and how that can impact their thought process or their emotional connection to that result, or what that means for them and their family members. So definitely different things that patients don't expect to go over during a genetic counseling visit, but hopefully overall great information for them to have and be aware of.
Wonderful, wonderful. Sorry for the interruption, but it's so interesting, so exciting. I think so many questions just as you talked about it. So maybe starting out, now that we know a little bit about what a genetic counselor is and what you do, so how would someone find a genetic counselor to speak with? And from the patient standpoint, what do you think would be some good or important questions that the patient should be asking or thinking about when they meet with a genetic counselor?
Yeah, I would say in order to identify a genetic counselor, you can always ask your healthcare provider. If you have a primary care provider, you could ask them. They may not be aware because genetic counselors aren't always embedded within healthcare institutions everywhere. We are a little bit more of an uncommon healthcare provider. So if you are at a larger institution, sometimes they do have those resources available and that they're aware of them. Otherwise, you can also go to a website that can identify a genetic counselor local to you, or one that you can identify via telehealth. That website is nsgc.org. It stands for the National Society of Genetic Counselors. And so that's a website where as soon as you pull up that first page, it brings up a link to find a genetic counselor near you. You can click that link, put in some information. You can narrow it down by zip code, state, however broad you want to be. And then you can also choose your specialty as well. I believe there is the opportunity to select in-person or telehealth visit. particularly with nephrology or with kidney genetics, I would recommend casting a broad net because not every genetic counselor works specifically within renal genetics. And so being more general, you may have more luck finding a provider local to you.
Thank you. Thank you. And then, so as I mentioned at the start, I primarily do transplantation, and it seems like the recognition of how important both APOL1 is and the need for genetic counselors in the transplant space has been, I think, a growing recognition of the importance, I think, particularly, but not exclusively, as we think about potential living kidney donors. And so what are your thoughts about sort of the need to have genetic counseling resources available to transplant programs?
I think it's very important. It's not broadly available currently. We are, again, not a common resource within all institutions, especially with all transplant programs. But I would encourage any provider within a transplant program to try and identify other genetic resources. If there's other clinical geneticists that work within your institution, or there are other avenues that you could access that information for patients, that would really be of benefit to them. So trying to identify those individuals, as well as maybe even finding a way to hire a genetic counselor to work within that program too. I think that's another way that things probably move forward, is in trying to incorporate more genetic counselors in that area. But it'll be slow to get there. It's been a slow movement already with genetic counselors, and it's just going to continue as more genetic testing becomes widely available in different areas, especially within the transplant program.
Fantastic. Thank you. Thank you for those great and insightful explanations. To the audience, if you're just joining us, I want to thank you for being here and being part of Kidney Action Week. You're tuned into our session. We should all care about APOL1 mediated kidney disease. If you have not already added a question, please drop your comments in the window next to or below the Facebook live stream. You can also add your questions to the chat box to your right if you're here with us on the Kidney Action Week website. We'll try to answer as many of your questions as possible. As we're getting questions for the audience, I think I have several questions for our two speakers here, and I wonder if I might start with you, Dr. Olabisi. Talk to me a little bit. You mentioned that APOL1 is more prevalent in individuals of recent African ancestry. We know that ancestry background is a complicated topic, so I wonder if you could talk to us a little bit about that and just reiterate for the audience what we're thinking about when we talk about recent African ancestry.
That's a great question, Dr. Norman. So when we think ancestry, the mind oftentimes goes to the question of race. But those are two distinct issues. So for example, race is a social construct, more or less. So that's not what we're talking about here. But ancestry is referring to basically where did your forebears, where did they come from? So let's put it this way. Individuals that have ancestors, recent ancestors, remember I said this gene evolved in Africa, West Africa specifically, very recently in evolutionary time, around 4,000 years ago. So people whose ancestor came from Africa, West Africa, around that time, or even closer, around 400 years ago, which is a lot of African Americans, which is a lot of people who are Caribbean Americans. Because if you trace the origin, the family origin of these individuals, you can trace it back to Africa. Now, somebody might ask me, is it possible for a white person to have the high-risk APOL1 genotype? And the answer is yes, right? If that white person have two individuals in their ancestry on father and mother side, who basically are of recent African ancestry, let's say they're African Americans in distant history, that individual can actually have high-risk APOL1 genotype. It's not very common just because of the issue of race in the United States, but it's possible. But it turns out that majority of people that carry this APOL1 genotype in the United States happen to be Black, or happen to, meaning self-identify Black, or African American, or Caribbean American, or even some Hispanic Blacks because of the way of the ancestry. So when we refer to recent African ancestry, we are referring to that history of origin. Where did your recent family come from? For the African Americans, it turns out to be a large portion come from West Africa. So that's what we are talking about ancestry. We are not really conflating this with race, because APOL1, as I mentioned, is not necessarily a Black-only gene. You can be not as Black, but if your ancestors in your lineage happen to be from West Africa, you can potentially carry this gene. But just the nature of how the thing shakes out, majority of people that have this gene happen to be Black, who are of recent West African ancestry. I don't know if that helps.
No, I think that's tremendously helpful and helps us be more nuanced in how we think about this issue. To that topic, as you mentioned, in the self-identified white population, or folks who don't have recent, see, I'm doing it, folks who do not have recent African ancestry, that the frequency is low. What is the frequency or the prevalence of the high-risk APOL1 genotypes in the United States?
It's less than 1%. And now the places where you are more likely to see it is among a white person that say has FSGS. And I'll give you an example. So in the context of COVID, having high-risk APOL1 genotype and having COVID infection turns out to be a horrible combination, in the sense that we are finding the kind of kidney disease we saw way back in the time of HIV, which is collapsing FSGS. It's the worst form of FSGS. More than 90% of people who have who develop collapsing FSGS from COVID happen to carry high-risk APOL1 genotype. In a small study that I did in my group, one of those individuals actually self-identified as white Hispanic, right? But when you genotype, that person carried 2 risk APOL1, which means somebody in her family, both on the father's side and mother's side, were Black from West Africa, but she may not know that, right? So, but the frequency of high-risk APOL1 in the general white population is very low. I would say less than 1%, if that's even generous. Among whites that have FSGS, I would assume that number might be a little higher, because that will probably track the history of African ancestry in some white. But even there, I suspect that the number is very low. So the general number to carry in the mind is less than 1%, but it's a non-zero number.
Perfect. And contrast that quickly, if you would, with the frequency in Black individuals in the United States.
Excellent. So if you look in the general Black population, where I am in the US and North Carolina, 15% on average of Black people in this area carry 2 copies of APOL1. That's 1.5. In the general Black population in the US, anywhere between 13 to 15% of Blacks. If you do the number, that's about 6.3 million people in the United States. Now, when you go from general Black population to Black population that have kidney disease, that number literally skyrockets. So among general Black population, the frequency of carriers of 2 risk APOL1 is around 15%, let's say. Among Blacks with FSGS, the number is 70%. So to give a fine point on it, if a Black patient comes to my clinic and has non-diabetic kidney disease, we did a biopsy and it shows FSGS, there's a 7 in 10 chances that that patient has 2 risk APOL1. That is a really outstanding number. And that number holds true by and large across the country. So the frequency of APOL1, high-risk APOL1 genotype among Blacks with kidney disease in general, but FSGS in particular, is 70%. Among hypertension-associated CKD, is about 40%. So as you move from general Black population to Black population with kidney disease, you see more Blacks with high-risk APOL1 genotype.
Fascinating, fascinating. And so building on that, Maggie, turning to you, given the frequency of APOL1 related kidney disease, what are your thoughts about screening? So thinking about screening, for instance, the general Black population, and then maybe some additional thoughts about screening the population of individuals who have chronic kidney disease for APOL1.
Yeah, I think it could be very important information for people to be aware of, particularly those who have a history of chronic kidney disease, identifying the cause for them. Sometimes there's feelings of relief that, maybe it was something genetic that I was already predisposed to. It puts them a little bit more at ease that it wasn't necessarily something that they did themselves to cause that disease. And then also provide information to family members too. I think it could be very important information. I don't know if there should be any official guideline that says that all individuals need to have this testing, but I do think that it's important that people be aware that it's available. If they want that information, they should have it available to them, and find the resources to do so. So, if you are interested, if you want to learn more information, look at nsgc.org to schedule an appointment with a genetic counselor to talk about that testing. It's definitely powerful information to be aware of. But always be aware that there's also pros and cons to knowing that. Sometimes knowing that information sits a little bit differently with every person. And so it's important to think about the testing first and then proceed.
You made actually a couple great points there that I wanted to follow up on. One that I know Dr. Olabisi thinks about is before the discovery of APOL1, this idea that folks who had disease that was progressing rapidly, that sometimes we would blame the patient for that disease and suggest that they weren't doing everything they could to manage it. And as you said, there's a guilt that goes along with that. And now we understand that they really had an underlying genetic condition responsible. So I think substantial both for the patient and also for physicians, providers as we practice. The other thing, if I heard you correctly, really, and when it comes to this genetic testing, is that it may make sense for us to think about getting the counseling first, because I think you talked about really the importance of understanding the pros and cons of the testing and the implications of the testing, and the importance of getting some of that counseling first. Would you talk a little bit about perhaps in the ideal state when we're talking about APOL1 or some of these other genetic tests, what the best approach would be in terms of getting to a genetic counselor, when the testing is done, sort of the order of this happening?
Yeah, so I would say the ideal situation is that a patient would be referred for a genetic counseling appointment. They would sit and meet with a genetic counselor, talk about their own personal history. We go through and get family history information, talk about genetics, genetic testing, pros and cons. The patient will feel informed. We'll make sure that APOL1 testing is the right test for them, that there's not more comprehensive testing that needs to be done or ordered, and then move forward with testing potentially. If we do move forward, it could take, on average, maybe a week or so, 2 weeks to get the results. It depends on which laboratory that you utilize. But then once we get the results back, it depends on where you've had the testing ordered from, how those results will be disclosed to you, and that can be a conversation with the counselor that you meet with. At our institution, we do results disclosure over the phone. So it'd be a phone call from the genetic counselor to the patient that says, these are your results, this is what they mean for you, and then providing resources. So if that means establishing care with a nephrologist, we can make that referral for the patient to do so, or following up with more information for family members. If family members are interested in receiving this information too, we can write up resources and letters that the patient can then take to those family members, that they can use that to facilitate a conversation about, this is the testing that I had done. You could be at risk of this, having the same condition or these same risk alleles. This is how you can get testing done as well. So definitely that's the ideal situation, not always practical in every institution. But at a bare minimum, I would really recommend, even if someone moves forward with testing for APOL1 risk variants, to at least receive some sort of genetic counseling post-testing as well, to make sure that they understand what the results mean to them and that they can act on them appropriately.
Yeah, Dr. Noor, can I chime in? So I think I want to make two important additions to that excellent point. First, that, and I'm remiss to mention this initially. So among the people that carry APOL1 genotype in the healthy population, studies shows us that having the high-risk APOL1 genotype does not mean that you are going to develop kidney disease. In fact, the number tells us that only about 20% of people that have this high-risk APOL1 genotype do develop disease. Now, that's a high number, but it's not 100%, right? So that's a good thing to keep in mind, that a positive high-risk APOL1 genotype in a healthy person without kidney disease is not a fate. It doesn't mean that you are going to develop a kidney disease related to APOL1. Secondly, there are, because of the, as we heard from our genetic counselor, we don't have enough genetic counselor, and we are trying to actually increase the number of genetic counselor. However, we can't wait. Therefore, a lot of studies, another option for people to actually get to participate in research that requires that offers the opportunity for testing it for APOL1 is through research. Research such as the one I lead in the Care and Justice, and I'm sure also with Vertex, we actually provide such counseling as part of the consenting process to people who come into the study. Now, the result doesn't go into your medical record because it's considered a research test. So it offers another way for the Black community to participate in research without necessarily waiting to say, when am I going to see my primary care doctor? Am I worried this is going to get into my medical record? Participating in the research offers an opportunity to get counseling about APOL1 before and after the test is provided. And the last point I want to make here was, there was a recent study published, I think, by Dr. Nadkarni and Horowitz in JAMA Network from Mount Sinai Medical School in New York. It's a very powerful study. They followed individuals, Black individuals without kidney disease or with high blood pressure. They screened about 5,000 people. They enrolled about 2,000 people into their study. And they randomized people into two groups. One group get tested for APOL1, and they reported this back to those patients. And the other group, they did not report it back to them until at the end of 1 year. And they said, what happened to the blood pressure management? Individuals that were randomized to receive information about the APOL1 genotype, and they also told their primary care, they also received counseling, their blood pressure went down. They were more compliant with their blood pressure medication. Their overall outcome view of their overall sense of wellness improved, and they also got more screened for kidney disease. So knowing the APOL1 genotype turned out to actually be beneficial in the community when it's done properly. So I want to say this to encourage that, yes, while we are trying to make sure the counseling is there, and it has to be there, the way to move forward is to, and in that study that I mentioned, the licensed genetic counselor actually trained professional staff on this research group to actually provide the report. So there are ways to extend the effort of genetic counselor, but I appreciate that effort is necessary.
Yeah, terrific, terrific. And I think your point was similar to what Maggie expressed in terms of having this information and how for some folks this might be tremendously beneficial to just to know what they have. You know, in thinking about specific populations who may need to know this information to help make personal decisions for themselves, again, thinking about sort of the transplant population, the living donors, potential living donor population. Maggie, if you would give us your thoughts about the screening of potential living kidney donors for APOL1 and some of the implications that you see.
Yeah, I would say we see a lot of patients who are at transplant center as living donors, and so APOL1 testing is a big push right now. And so um, when an individual steps forward as a potential living kidney donor, they're stepping forward with the mindset of trying to help either potentially a relative or someone that they care for or they closely know in most situations. And so their motivation is to help that individual. Oftentimes when I meet with people, we talk about APOL1 testing and talk about what that information could mean for them. And oftentimes they're not really thinking about their own health care or what that testing result means for them outside of transplant. So that's something that I try and take some time to explain to them and go over because they're interested in the information to know if they have a higher risk of kidney disease in order to help in that situation of giving a kidney, but they don't always think moving forward what that means for their healthcare management from that point on. So like before it was mentioned that this could improve this, just knowing this information could improve an individual's health management adherence. So it's really important for them to really think through the implications long term, not just in that situation. But we're definitely seeing a lot more individuals as living kidney donors stepping forward, being interested in this testing and discussing it with them and helping them to make the best choice and decision moving forward as a living kidney donor, and then taking that information long term and applying it to their own healthcare.
Great. And then building on that, Dr. Olabisi, in your center, what have you seen in terms of potential living donors who've had APOL1 testing? How is this impacting people's willingness to donate, or even the center's willingness to approve them as potential kidney donors?
Yeah, that's a great question. And I think maybe for the audience, if I step back one step to say, why do we actually ask whether to determine the APOL1 genotype of a donor, right? The concern here is if somebody that carry APOL1 genotype donates a kidney, does it put that donor at risk subsequently after they donate? Does it make it more likely that they themselves will have increased risk of kidney disease or kidney failure that ends on dialysis? And I would say that the ultimate study that will help to answer that question is the Apollo study. That study is going on. So we don't have a definitive answers on that. Now, there's a small study that looked at around 120 people, Black individuals that donated kidney, and they followed those people over time. Now, they asked, what is the likelihood that somebody developed kidney failure after donation? There's a small but significant chance, I think about 10% of people who have high-risk APOL1 who donated develop kidney failure themselves afterward. Now, that's not everybody. It's 10%, and it's a small study. But that, for me, is enough signal to say we have to work into this carefully. Especially in the Black community, as you well know, Dr. Norman, there are two challenges. Most people that receive living kidney donation receive it from a relative or someone they know. So if we deny people the opportunity to receive living kidney from relative or family members, it's a huge disservice. On the other hand, we don't want to say everybody with high-risk APOL1 can donate, because if some of those people, even if the 10%, that 10% is too high a number, but we don't know that for sure yet. If those people develop kidney failure, I don't think that's acceptable by the society community. That's why a study like Apollo would be important. If the Apollo study, which is relatively large, tells us that actually donating while you have high-risk APOL1 is safe, I think that will give us the freedom to say people should go ahead and do it. If it shows that a large proportion of high-risk genotype carrier develop kidney failure, it should give us a pause and understand who can safely donate with high-risk genotype. In my center at Duke, they actually offer it to donors. It's up to the donor. They provide the information. They said, do you want to do it? And some decide to actually do check before they donate. Some choose not to go for it, but it's an option that is provided. I think this question needs to be answered in the service of the community, but we do not have enough evidence to really come up with a policy one way or the other. But I agree that donors should be informed. They should have the information, and at this point, it should be their decision.
Fantastic, fantastic. Thank you. You know, you mentioned the Apollo study. So while we're talking about that, in your early slide, you talked about the low participation rate of Black individuals in research studies. So I wonder if you could spend a minute or two just commenting on why is that?
Yeah, this is a really excellent question. So some of this, in fact, I would say maybe a lot of this come from historical memory. If something hasn't worked for you in the past, you probably don't want to do more of it. The community has a long memory, and maybe it's not even that long. Tuskegee trial is not long ago. As you know, this is a study of syphilis where African-American men were enrolled in the study and observed over time when there was already treatment for the syphilis that afflicted them, and they watched them to see what happened, to look at the natural history of the disease. There was a lot of loss of trust in the community. So maybe I'll call it trust deficit between the Black community and the research community is a big factor. Another factor is the way that our research infrastructure is laid out. We do it, we say, come into our space, come participate in research on our schedule. But I think we need to engage the community actively. We have to say what works for the community and how can we elicit community participation. So there are multiple factors that the traditional way of doing research may not work for many people. You're doing 2 or 3 jobs, you may not be able to take time off to go and give blood or to go and do some clinical trial. So how do we structure a clinical trial to fit the way people currently live so that it will encourage them to participate? And we have to be honest, we have to face what has happened in the past. In what ways has research not worked for African American in the past? We have to own up to it and say, how are we going to make the difference now? We have to partner with community leaders, just as the people did with COVID. When people see their community leaders basically vouching for certain research, they are more likely to participate. It turns out that African Americans are just as likely to participate in research as anybody else when they see that it's in their interest. So it's the owners, it's on us, researchers, to make it clear, why is this research in the interest of the community you live in the people like you? So I think the lack of participation has multiple factors. Maybe we haven't really gone into the community as much as we have gone into other communities, but we need to address those lack of trust, especially between the African American community and research organizations.
Tremendous, tremendous. Thank you. And thank you, everyone, for your questions today. I want to thank both the audience and our speakers for joining us and participating today. We're now going to pull up a key takeaway slide that you can reference for some of the major points from today's session. And as you're reading that, I'm going to ask our panelists to share takeaways of their own. Meg, I'd like to start with you and really ask you, if you had 2 key takeaways from today's session that you'd want the public to know as they leave, what would those be?
I would say that APOL1 testing is available to you. It's just how to get it and where to get it. So there's definitely different avenues, as you heard from myself and Dr. Olabisi. You could do it via the clinical testing route and visit nsgc.org to identify a genetic counselor who may help you facilitate that testing, or you can do it via a research route. There's different avenues available. You might have to ask around and try and detect those different resources. And then I'd also say that, it's important information, and that if you are interested in genetic testing, always just take a second to think about what that genetic testing could mean to you, or what that result would mean for you, and think through, do I really want to know this information or not? And just try and identify a resource if you need one before or after a test is ordered.
Thank you. Thank you. And then Dr. Olabisi, 2 key takeaways from your standpoint for today.
Well, if I can distill it down to 2. So one is that the APOL1 thing is not a fluke. This thing really affect the community. Is a space I've been in for the last 10 years or so, working with people who actually preceded me in this space. So this, if we are looking for a way to increase kidney health equity, especially in the African American community, something we can rally around, a problem we can solve that will reduce the number of people, Black people on dialysis, I would say this is one of them. In fact, this is an important one. How can you get involved? As Maggie said, you can go the clinical route, but for people who might be worried about health insurance and all that, I would say participate in research. A lot of us are in this space trying to, Dr. Ogo and Vertex and whatnot. So I would say encourage you to participate in research. Our website as listed, Vertex also have information on their website. Look for those information, go to the AKF website. It will link you to the where you can get more information. But I would say for change to happen, we need the participation of the community. If there's any information I will leave today, that's what I would want to leave us with. So we all can do something about this.
Thank you. Thank you. So I want to offer just a huge thank you to both of our panelists today and for everyone who's joined us today. There's so much to talk about when it comes to preventing kidney disease, and we can't wait to bring you both back in the future for some additional chats.
Thank you.
For the audience, thank you. If you, for the audience, if you or someone you know has been diagnosed to have the APOL1 variant, we'd like to hear from you. Please consider joining our Patient Brain Trust to help inform our APOL1 work. For more information, please contact education@kidneyfund.org. If you haven't already, please follow us on Facebook or send us your email through the kidneyfund.org site, and you'll be the first to know about other resources like this great webinar we had today. Also, make sure you check out the agenda for the rest of Kidney Action Week. Once we conclude this session, you'll see a link for a quick survey in green below the video screen. Please take a few minutes to fill it out and tell us how we did today. Your feedback will be very helpful to us as we plan future sessions. Please stay tuned for our mini session, Mental Health with Al Lee, starting at 5:05 p.m. Eastern Time, 2:05 p.m. Pacific Time. The session that will follow Ellie Lee's session will be a rebroadcast of our earlier session, The Past, Present, and Future of Testing for Kidney Disease, and will begin at 5:30 p.m. Eastern Time, 2:30 p.m. Pacific Time, and we hope to see you there. Thank you, everyone, for your time and attention, and have a great rest of your afternoon.